So welcome back, everybody. We better get going if we're going to keep to schedule. Thanks a lot for yesterday and your input to this workshop, the work that you did. We're going to just spend a little bit of time, first off, to go through the messages which we got out of it, because what we want is for what comes out of this to be more than just the sum of the parts, which often happens with a symposium. You just have a summary of all different presentations. What we want to do is try and distill from all the presentations the real messages that the Commission needs to be thinking about as it develops its report. And then after that, we will be moving on in the life course. So yesterday we looked at the adult life course. We looked at people in robust health. Then we looked at people who were having declining capacity. Today we're going to start by looking at people who've already had very significant losses and how can we structure a social response to their needs. And then we're going to look at how do we actually translate knowledge into action, and ultimately how do we build systems. And what are the systems we should be looking at in our future back model that we would like the world to have in place by 2050 or whenever. So I'm going to pass to Sharon, who's going to take us through what some of the messages we heard from you yesterday. If there are others which you think are really important, which we haven't captured, please let us know. There was the email address where you can send that, or just approach us and tell us about it, or bring it up in the sessions. So Sharon.
Thank you. Well, good morning, everyone, and thank you. Just a little recap on some of the themes that we identified from yesterday. And just a reminder of that email address again to send in any thoughts you may have. If you don't have time or inclination to raise it here, you can email your thoughts and ideas in to us. So thank you again for the great discussions, and you really lived up to John's call for work and being a really great working group. And here are some of the major themes that came from our whiteboard over there. So some of the major themes from Finbarr Martin's keynote were to think beyond disease and really to think about the underlying age-related changes that are occurring in that person. Think about the person in our person-centered focus within their context and their environment. And then this thought of integrating care across all sectors. And then to think about workforce changes that are needed with education in geriatrics and about frailty across all specialties as being very key. So those were some of the key themes that were pulled out yesterday. From session one, the session moderated by Linda Freed on a future back vision of healthcare and public health to achieve healthy longevity. One of the major themes that came out was that prevention works and matters, and prevention needs to occur early and consistently, and we need to apply direct prevention to the red zone. Remember that zone of where we can improve health span. So not necessarily just focusing on prolonging the lifespan, but really to improve the health span. We talked about institutional change needed in response to demographic changes, and that much of the evidence already known is not being used or applied, and that institutional change is very difficult, and systems are very resistant to change, as David Canning highlighted. And to create change, we need economic incentives coupled with disrupting social norms. And we spent a lot of time discussing how to disrupt those social norms, very, very important issue. Inequity is a major issue highlighted throughout all of the sessions, with huge disparities in well-being by income groups. And we need to think about broader measures of health, measures that incorporate capabilities and that capture meaningful life and life purpose. But it was stressed that we can't, though, not create change because of waiting for the perfect measures. All of our measures are going to be imperfect. None will be ideal. And perhaps the best and most important thing, because change is needed now, is just to select one of these imperfect measures that already exist, set targets, and then measure over time. And that setting those targets can be a very powerful way to start to institute the change that we hope to see. For session 2, and please, again, if you don't agree or you want to give more feedback, or any of the panelists say, hey, that wasn't my major theme, it's this, we welcome you to give us that input. We want that. We're just like setting this down so we all have something to talk about and something to build on further. So from session 2, which was maintaining robust health of aging people, so these are people that are healthy, are robust, and we want to keep them that way as long as possible. So making the invisible visible was one of the major things. We need to address disparities. We need to reach the marginalized and the isolated, who often fall into these disparities groups and are overlooked. And then we talked a lot about integrating the 3 domains of life: education, work, and private life, and change our funding system across all 3 domains in parallel, or change the incentives across all 3 of these domains in parallel. A focus on reinventing work was a major, disruptive suggestion, and to make investments across the life course to foster all of these domains, and one example being lifelong learning. We need to make investments where people live and work. And we talked about modern urbanization, creating age-friendly cities, age-friendly communities. I think this is a major and important suggestion. We need to work to integrate healthcare and social care and create conducive environments where all elders can age in place. We need to develop policies that recognize both the vulnerabilities and the capabilities of people, again, so you're seeing these changes in our measures and our metrics and our policies. And again, major change in attitudes are needed to create these change and disrupt the ageism. And then leveraging data and metrics to create sustainable approaches. In session 3, this is supporting the individual needs of people that are having declining capacities, so people at that early and moderate stage of decline, and EK was our moderator for this session. And there were a lot of themes that emerged from this session. Prevention of frailty and functional decline was highlighted, with functioning and maintenance of functioning being a key outcome measure for our elders. I really love this term about the age-proud movement. So to counteract ageism and really to celebrate aging, again, stressing the need to change social norms, creating large-scale media campaigns. There was a lot said about how the media kind of entrenches these ageist views. Very important to figure out how we can change that. And then when we were talking about development of new technologies, it was very apparent that ageism and bias can be incorporated at every step of developing those technologies if we're not aware and if we don't make purposeful efforts to really try to counteract that. We talked about person-centered care and putting the patient and family at the center of all care. And personalization of care according to the goals of the individual, and having individuals co-design our systems of care, our technologies, our supports, et cetera. A lot was said about the disruptive technology solutions to enable healthy longevity. Again, I think this is an extremely exciting area and one that is going to really contribute to helping us create a healthier longevity. Many examples already exist. You know, there are many features in terms of voice control, electronic health record interventions. talked about scalability, the importance of that, interoperability, and sustainability. And public-private partnerships came up very many times during this discussion and others for both development and implementation of these types of changes. We did start a discussion about responsibility for care. Who's responsible? Is it the government? Is it the private sector? Is it communities, neighborhoods, families, the individual? And of course, the answer is all of the above, need to play a role in providing the optimal healthy longevity. So as you can see, going across all of these, there were a lot of themes, unifying themes that came up again and again across all of the panels, and also some transformative themes that I think are very important and that I hope will carry through today and beyond. So the importance of prevention, that was really stressed in I think all of the panels. And this is really how we get to improved lifespan and to compressing that red zone. I think every panel focused on inequity as a huge issue that we need to address upfront, eyes open. As we innovate, we need to make sure that we can reach all populations and that it's not just an aspect of improving health span for people that are well off. We need a broader definition of health. I think that's going to be really key, including vulnerabilities and capabilities and focusing on maintaining function as a key outcome. We need to counteract ageism, and I think that disrupting those social norms, that's going to be one of the most important and necessary steps that we need to take. If we don't accomplish that, I think everything else we try to do will be futile. We need to find a way to celebrate aging and to make aging a focus of our whole society, putting the person and the family at the center of all care, reinventing work and investing in work and lifelong learning, I think will be key across the life course. We need to think about our metrics. Obviously, we need to improve them, but also I think the key message of not letting that hold us up from setting targets now that we can change now. And then this aspect of shared responsibility, I think, was really key. And I think the private and public partnership working together, but also realizing that neighborhoods and communities and families themselves, also have to play a very important role in creating the change. So what's next? John outlined the sessions we're having today. And our goal is to try to get closer to real-world operationalization. I think we had a great start. A lot of things that we talked about, though, were from more of a 50,000-foot view. And I think we want to really get to how we can think about the priorities on the ground. So let's put our thinking caps on together. We're asking you to work again, but I think we have just enormous potential to create the priorities that we need to address moving forward. So thank you so much, and remember again, we want your feedback on this. Do we have time, CC, if anybody, to give feedback now? Maybe two? We need to move on. Okay, we need to move on, so please, thank you. So please feel free to email in your comments and we will address them. Thank you.
Yeah, and also good morning from me from Denmark and from Roskilde, and I have promised on behalf also of Eduardo to make an introduction to this workshop. We will continue from this discussion about significant loss of capacity. and also perhaps acknowledging that even if we have a good prevention, there will be a time of life where people have a less ability to be functioning in, you can say, an optimal way and will need some kind of care. Therefore, this workshop, or this session, so to speak, will be focusing more upon and move a little bit in between healthcare and long-term care, where we yesterday, to a large extent, focused on healthcare. There will be more about long-term care in this section. I mean, aging of population, as we heard, it will be something for all countries within the next 20-25 years. We will know that even, as I said, we do a lot of preventive measures, there will still be a need for care. And also so that we are not aware of, and even if we have knowledge about some kind of intervention which will have an effectiveness, we're not aware and have sufficient knowledge of all kind of intervention having an impact. And I mean, we have been giving for this session also a few questions and objectives to look into. I'll come back to in a second. We've also been asked to, which makes it a little bit more difficult, to try to think about across the globe, from high income to middle income to low income countries, to countries which are normally speaking about welfare states in Europe, to countries which has not developed to the same extent a state type of intervention in welfare. And we will try to do that by the different perspectives from the panel, which I'll come back to in a second. And the objective we have is also to, besides them, to look across the themes of what we've been discussing, including yesterday, which, for example, includes how will carers be able to have a job on the labor market. So there might be a contradiction between carers and those to be cared for, which we can come back to during the discussion later on here. So, I mean, we're going to try to explore the challenges and opportunities to integrate long-term care, healthcare, and social care. And here again, we have not only between different countries, but we also have within the countries different levels. In some societies, we have a very decentralized type of provision. In others, we have a more national provision. And there needs to be some kind of interaction between these different levels in order to give the best possible and available care for those in need of care. We might also come back to, I mean, we have a lot of countries a discussion about what is in fact need. Yesterday we were told that you have one simple measure to knowing whether people were in need of care. There's also somebody talking about unmet needs. But even if we have an unmet need we're not sure about, which is part of the next objective, how to finance these kind of unmet needs and how far it is the role of the state, how far is the role of the local society, civil society, how far it is the ambition of let it over to the market or some kind of public-private partnership. There are many variations in how can do these kind of approaches to supply and implement different kind of care. And also, as one of the cross-cutting themes is, what will be the impact on access and equality for care? Will that be the same in all different models, the same in all different kinds of way we're doing it, etc., etc. So even if we emphasize the right to care, how can we ensure that we are improving health and well-being, autonomy and dignity for care receivers, but also for providers and carers in different settings and different kind of setup? We've also been asked, and there was also in the summing up this morning, some discussion about new kind of possible technologies or kind of welfare technologies. We know a lot about a lot of them, but we also know that a lot will be coming in the years to come. And how far might welfare technologies be a way of supporting those in need of care, who we can say perhaps health care is no longer what is needed, but it's something else we will have to do. And how can we ensure that as over generations is some kind of solidarity and social inclusion for different persons. We have, as you can see up here, 4 distinguished speakers. We have a good gender balance. This is also one of the social development goals, to have a good gender balance. And they have promised to be brief. I come from a country where we try to keep the timing and short, so therefore they have been told they have 5 minutes. If I start raising my body a little bit, time is up. Then we'll continue, because it's and I agree with, it's important in such kind of meetings also to have interactions with the audience. So there will be time to have an active debate and asking questions, but then of course also they're clear and precise, so there's some we can have an interaction and discussion about how we'll do it. You have heard Martin yesterday, and he will be the first today as well, but not for 45 minutes. I know that's something we can say for university professors. They don't need a watch. They can have 45 minutes in the back. So when they start speaking, they can always speak 45 minutes without doing it. But you have 5 minutes to the first to talk about those with loss, significant loss of capacity, and how you will say about that. Martin?
Okay, thanks very much. Okay, so what I'm going to take a very sort of limited perspective. I'm going to talk about describing what seems to me to be a description of the needs of people, and just take the sort of person I'm talking about here is a person that for any sort of basic quality of life would need one or more interactions with somebody else to manage their day. And up to and including care that would be, on an almost continuous basis. I'm talking about that part of the life course for some individuals. What I'm going to describe it briefly is 3 different systems or 3 different approaches to describing the range of those needs, without any particular view of the superiority of them, and then to talk about, from my own experience point of view in a care home setting, how some of that translates. So first of all, the International Consortium for Health Outcomes Measurement has an organisation that I've not been involved with, but it has produced a standardised set of health outcome measures for a variety of settings, including a generic one for older people. This was a standard set that was a collaboration of experts, research, patients, and older person advocate bodies. And they produced a set which described a number of domains that seem relevant. And these include, in health outcomes, clinical status, which includes things like survival or experience of healthcare in terms of how long people might be in a care system, the quality of death, the level of functional ability, loneliness, pain, the sense of participation in decisions about them, experience of falls, mood, activities of daily living, and sense of autonomy and control in the context of receiving healthcare, and also the perceived carer burden. And all those things are associated with metrics that sort of can measure those in terms of quantitative things. How much do people feel, for example, they participated in care? Do they feel lonely in the experience of care, and so on? So that is a model which is quite broad, and what I think it underlines, and where it has some utility perhaps, is to emphasize that when we're thinking about care in healthcare situations, the key question has to move from what is the matter with you to what matters to you in terms of actually thinking about the content of care. So that's partly, in a sense, a tool to articulate a discussion with an individual about what person-centered care might be, identifying priorities. The second model I want to talk about is very, very old indeed, the Maslow Hierarchy, which I'm sure psychologists have looked at, developed, perhaps rejected over many years since it was described in 1943. And this was an attempt to sort of differentiate the different sort of levels, as it were, of need, with the 2 basic levels of need being described as that sort of physiological, i.e. the basic need of a human being for food and water, and also for some degree of physical safety and possibly mental safety. And then the higher levels there that people would aspire to in terms of need, which, as long as those basic ones are met, which would include things like love and a sense of belonging, a sense of self-esteem, and indeed self-actualization, the ability to sort of direct and make choices about the way that you're being and you're living. Some of those concepts, I think, are encapsulated in the WHO domains of functional ability, remembering that the functional ability is key to well-being in terms of the WHO definitions, and functional ability defined as the ability, the things that you have reason or to be or to do, reasons to value. And that describes those domains in terms of basic, what you might call physical needs, the ability to learn, to grow and make decisions, the ability to be mobile, to move from one space to another, the ability to build and master relationships and maintain those relationships, and the ability, importantly, to contribute to the situation around you. So that's another sort of way of describing a set of needs. Now, let me just reflect on my own experience in the particular setting of being a doctor in a care home, which was part of my clinical work over 30-odd years. And so if I describe that in terms of, let's talk about the basic, the physiological, that need then requires an understanding of the individual's abilities to do certain basic things and the extent to which help is needed, but also the extent to which the receipt of that help has its own burdens as well as risks and preferences. Autonomy in some aspects of care, and this is autonomy in the face of high degrees of personal dependency. And two examples of that in a person who has significant care needs would be, for example, choices about preferences of how health emergencies would be dealt with in terms of actually preferences for reducing burden or maintaining long life. Sometimes there's a choice there. And that would be relevant to, for example, to an individual choice about if they have an infection which is potentially treatable in a hospital with more effectiveness than in a care home. Do they value that more effectiveness, or do they actually prefer the familiarity of where they are and the less burden of where they are? And indeed the risk of being ill and dying in the context of some relationships rather than strangers. And the other one is a good example of one I came across, a very practical issue, and that was, do the care staff allow foxes to wander in an open door and sit at the foot of a bed of a man who's dysphasic and can't express that, but whose job as an illustrator for books included drawing animals in children's books, and whose wife was adamant that actually his preference would be to watch the fox. The preference of the staff was to have the fox well out of the way and the door shut, so not even the wind could be felt. So that's a good example of the conflicting needs of those two agencies, the individual and the staff. Relationships, important in that, and that's about things like how do you arrange interactions between that individual receiving care and staff in terms of continuity, in terms of choice, in terms of time. Identity, that is, particularly in countries such as where I live in London, the possibility of the caring staff and the cared for person having the same cultural background or same historical memories of things like local events or factories or where they worked is very, very low. So therefore positive efforts to actually make familiar what is the life, what has been the life of this person, and what's this person's sense of themselves. And there's a number of initiatives to try and encourage that, to enable that, so the person's sense of a continuity of their life is promoted, rather than this being a new and isolated and completely strange event of being in a care setting. And finally, of course, there's the issue of altering the trajectories that individual might experience through specific but proportionate actions to try and preserve intrinsic capacities that individual may have. So all of that requires a fair degree of complex assessment and knowledge, as well as an appreciation of the individual's priorities. Thank you.
Thank you very much. You have all the biographies within your material, so therefore I will not saying a lot about individual persons saying something, but we continue, and now Anne will say something about long-term care, because we have talked a lot about healthcare, but now you have an ability to both define it and say what's the borderlines with healthcare and where is the interaction possible.
Well, thank you so much, and also thank you for inviting me here. Maybe some confusing thing for me is that I'm now from Switzerland. Well, I have been at the WHO for 4 years, leading the work on long-term care, but now I'm back in the Netherlands. I'm originally from the Netherlands. But I think the things that I will tell you now are very much related to the work at WHO. So in that sense, it might be good to have Switzerland here. So what is long-term care? I think often what we are doing when we are trying to answer this question, what you hear around you, is that people try to sum up several services like home care, daycare, nursing home care, that type of services. Now, that is very much a service-oriented perspective. Now, what WHO did was developing the healthy aging model, and based on that model, we are having a person-centered approach instead of a service-oriented approach. There is a paradigm shift, and I will try to explain what that means. And that might be a challenge without any picture, but Finbarr, yesterday you showed the healthy aging model. I don't know if you remember, but with the lines during the life course going down, and then the 3 pillars. So you have a group that is rather stable in their capacities and ability, and then a middle group that is starting to decline on average. And then there is a third group that has a significant loss in capacities, in mental or physical capacities. Now we are talking about this third group. So we are not talking about specific services, but we are talking about the focus of the care that should be on people with a significant loss in capacities to try to keep their functioning, their functional ability, as high as possible over the life course. So first, long-term care is meant to address a person's unique needs. So it's person-centered. But secondly, it focuses on keeping your functioning as high as possible during your life course. And that is something that might sound easy, but it's not always that easy. So for instance, sometimes when people, I give you an example, when people have difficulty to do the shoppings, for instance, what often happens is that we completely take over the shoppings and help the person in that way, in our view. But if you look at that model of healthy aging, then what you should do is looking at what the person still can do themselves. And so it's about self-determination as much as possible, and keeping the functioning as high as possible. So taking over all the shoppings is maybe not the right thing to do, because in the end of the day, it might not keep your functioning at the highest level. If someone else is doing the things that you still can do yourself, maybe when another person makes a shopping list or brings you to the shopping mall or do something else, while the other things you can do yourself, and then that's preferable. Now, it's like what you already said in the first short presentation. It's not only about basic needs, but also about staying mobile, relating to other people, learning, growing, all these kind of things. So it's not only about basic needs like that people will bring you to the toilet when you are not able to use the restroom anymore. Long-term care can be provided in a range of settings, from your own home till the nursing home and everything in between, or setting. It can be provided by a range of caregivers, family caregivers, unpaid, paid caregivers, volunteers, whatever, and through different financing mechanisms. So this is the concept, how it is defined by the World Health Organization, different from a service-oriented perspective. And of course, it might sound highly aspirational. There are huge differences referring to the different countries that we have in the world. Some countries have nothing and everything needs to be developed from scratch, while other countries have a lot in place and have very developed systems, like for instance in the country where I come from, the Netherlands. I would like to add some of the challenges that are related to long-term care. And we will not solve that in this 5 minutes, but I think it will be good to raise a few of these issues, and some of them has already been discussed yesterday as well. And the first is the accessibility of the care. And I will start with the family care, because not everyone has a family member. And for instance, in Africa, often what you hear is that the family should do the job, while, for instance, in Tanzania, 1 in 5 people don't have a caregiver at all, a family member that can provide care. So it's good to keep that in mind. Most of the care, if we talk about family care, we are talking about females who are doing the job. Daughters, wives, and of course the world is changing, so they aspire other things to do, have paid work. And also children, for instance, are moving away from rural settings to urban settings, leaving their parents behind. So talking about family care, you need to realize that that it is something that is changing in the whole world, basically. And of course, not everywhere there are paid services. Sometimes there are other models like the use of volunteers, but I would like to stress that that is not a solution for everything, because also when you have volunteers, still you need to have some other services, because otherwise what would these volunteers do? And so using volunteers can also create a request for services, for other services. Now then there is the financial sustainability, but I'm sure, Adelina, that you will expand on that. But I would like to say a few words on the quality of care, and that also has to do with the workforce, because you know, basically in many parts of the world, providing care to another person is viewed as a dead-end job, as something that is not worth to have any education or whatsoever, while basically this is a very difficult job, complex job, and you need training for it. And that holds for family caregivers, but it holds also for paid caregivers. Now, I think also the payment is good to mention, that often the people who are in these jobs are paid a very, very low salary. And the image and the status is also something that we need to change. And actually, I think in the Netherlands right now, there is a huge movement to try to improve the status of the job. And there is, the minister is putting a lot of effort in this respect. But you see, slowly, but it is changing. So I'm hopeful about that. And the other thing that we might want to consider are the role of migrant workers. And often their rights are completely neglected, and yeah, and there's abuse. I need to finish, yeah?
Yeah, I think
okay.
so. Yeah.
Okay.
Thanks, Lara. I know it's only short, but it's always good to learn to be short sometimes. It's not always the long presentation who is the best. Sometimes it's the shorter, distinct presentation. I've learned. I'm not always good at doing it myself, but I have been informed that this is sometimes good to get your but thanks a lot. We continue with Adelina from London School of Economics, and you will say something about dementia and
financing.
And financing, yeah. And I think the reason is that we are a few economists here, and when two economists are in a room, they will always talk about how to finance it. So?
We always say that there are elephants in any room, and I think financing is always one. It's also something that we know we should really think about, but it's very hard, and because the numbers can be quite big. But I'm going to start with thinking a little bit about, so say there's a lottery as to which conditions you might get. So you might get some things, others you can be very good and do a lot of running and healthy eating, but you still might get some things until we manage to find a cure for everything. So imagine you get cancer, or you get a condition that is seen as a proper health condition. then almost all your care not in all countries in the world, but in increasing numbers of the world, and also you will find that you have a huge backing of the World Health Organization, the World Bank, towards universal health coverage. And you'd want to think that the health care of people who develop this type of conditions, say cancer, should be something that we all financially cover, and we all make sure that people don't suffer a catastrophic risk, that they don't spend all their money in order to achieve care. But say instead of cancer you get dementia. Well, it's not so clear that there's a movement internationally behind making sure that the families that are coping, or the individuals who are coping with dementia, are protecting from losing all of their savings and assets. And that's because when you have cancer, most of the care that you need is within the health system, and we have systems, and we have grown also across the world, I think, and with some very big exceptions, but most of the countries, to appreciate that it's very important to finance health collectively, to share the risk among the population, and those who have the luck of having one of these conditions, between all of us, we support their care. If you have a condition that develops in other types of care needs. So you need maybe more personal care. You need somebody to make sure that you stay safe, that you don't get lost, that you need help with getting dressed, you need help with bathing. Because that's something that traditionally the families could do. We never really thought that this was something that we had to develop a system for until quite recently in some countries. There are many countries in the world that don't see this as a role for the state or for the public sphere to cover the costs of care. There are a few countries in the Nordic countries, in the Netherlands, where you have some very well-developed universal systems where everybody who has any personal care needs in particular will be covered. So we have a very different, depending what condition you get, you're treated very differently. And the main reason, perhaps, that you could see that this is the difference is because if you had a condition that required specialist knowledge to address it, so your health, somebody who understands health, then you couldn't do it yourself. You needed somebody who had a specialism. But if you needed care, anybody could do it, so maybe that was not something that we had to take care of. But things have changed. They have changed a lot. And what we are appreciating is that this care that the families were providing is not necessarily free. And just to illustrate a bit what happens when somebody has dementia, in the UK we've been looking very carefully, in England actually, at what people with dementia use in terms of health and care and how much it costs. And we found that only 16% of the costs of care of a person with dementia are due to health. Of that, 8% are hospitalizations. So only 8% of the total cost of their care are due to what we'd call, normal routine treatment, monitoring of their condition, diagnosis. All of that is only 8% of the entire cost of their care. Everything else is long-term care, or personal care, social care. We can define it in different ways. Out of that, about half in the UK and England is done by the families through unpaid care. But also even within the formal care part, which is 42% of the cost, only 12% is publicly financed. So individuals are bearing, in fact, if you add up unpaid care and the private contributions to formal care, individuals are paying for 68% of the total cost of their care. So 2/3 of the cost of dementia are not shared with other members of your country. You pay for it out of your own pocket, out of your savings, or out of your own time, or the time of your relatives. And that's telling us that social protection hasn't reached dementia, and that people with dementia and families in many countries, not in all, to the same extent, or in some countries even more than in the UK, these people are being left alone, these families are being left alone to cope with a very big risk. It's also a risk that is growing very fast. I know there's a lot of research into finding disease-modifying treatment, but I think it will take a few years to get there, and very few countries have systems that are ready to provide the care that people will need. And we know that the numbers of people with dementia are growing really, really fast, especially in middle-income countries where they don't always have the health and even less long-term care systems that are ready to provide adequate care. So as part of a project I'm working on called Stride, we're doing, in fact, I love the fact that here you talk about Future Back, because that's also what we're trying to do. We didn't come up with such a neat name, so we might borrow it. But what we're doing is we're working with stakeholders from a number of sectors, because dementia is not just one sector, it's not only health, it covers a wide range of ministries, of players. We have the providers of care, we have the families who actually do a lot of the provision. So we're working with all of them to try and understand where they'd like to be in 15 years. We're doing that at the moment in about 10 countries. 7 of them are low and middle income countries. And we're trying to then work out in numbers, what do we need to get there in terms of financing and in terms of workforce. And the workforce is a huge issue because many of these countries are the countries that are providing the workforce for care in other countries. Now I'm going to say one more point, and this is about the role of families in providing care and the sustainability of long-term care financing. So as Margriet was saying, in many countries they will say to you, well, the families do it, so why don't we just let them do it? It's free, it doesn't cost us anything. Why should the state interfere and intervene? Well, actually, it's not free to provide care. And I think as economists, we haven't done a very good job yet at putting this point across, particularly to ministers of finance. In fact, family care is the largest financing mechanism for long-term care. We have other financing mechanisms. We have savings. We have long-term care insurance, which may be private or private. It might be like in the case of Singapore, is a very fascinating combination of private provision, but also very heavily regulated. So it's almost everybody should be able to access it. You might have a tax system. You might have a social insurance system, depending of your infrastructure in terms of the way you've developed your welfare states. You might decide to go for taxes, social care. All of this to me is quite minor. What really matters is what's the role of family in providing care and what the implication of that is. And why is this so important? So we're talking about sustainability, we're talking about aging, we're talking about populations where the proportion of the population who are of at least what we used to call the traditional working age is shrinking. And what we're finding is that there are still very large numbers of people in the UK. In 2015 it was 345,000 of carers of working age who give up work to provide care. Out of those, 60% were women. And we think, oh, okay, well, maybe they take a bit of time out, but then they'll go back into work. Actually, there's some work from the US and from Germany that's looking at the long-term impacts of exiting the workforce to provide care. And if you left for 2 years in the US and you were a 50-year-old woman, these 2 years of lost wages were on average $21,000, and that's because those women who give up work to provide care are the lowest paid, who can't afford replacement care out of pocket. But when they looked at what happened longitudinally in the next few years, in the next 10 years, they found that the actual long-term care costs due to difficulties rejoining the labor market and reaching the same wages that they might have had before were $51,000. So this is a lot of money for 2 years of care. It's actually not economically sustainable. It doesn't make sense. It's not good value for money, because this disruption in the labor trajectories of these people, and this is only also the cost to the individual. Here we have added the cost of the fact that these people might then be needing benefits to compensate for the fact that they may be in poverty as a result of these interrupted careers. They may have foregone pensions, and that again makes them more dependent. They may even be more likely to be eligible for Medicaid in the US. So, you are actually creating future fiscal dependency through not having acted earlier on in people's careers. So how do we go to more sustainable approaches to care? First of all, we need to pay a lot of attention to the type of care people are provided, to the intensity of care they're providing. To provide care to your spouse when you're both retired and it's quite manageable, it's a beautiful, wonderful thing that probably all of us want to do. But to have a carer who's providing more than 20 hours a week and has to give up work in a crucial part in people's financial career is a completely different situation. And we have to have systems that allow us to take a longer term approach to the fiscal implications and poverty implications even of not having provided replacement care for these people. Other policies we want to look at, which is quite simple, is to make sure that countries offer care leave. So if you have, and your employer, if you leave your work because you have a child, usually you get an entitlement to some care leave and you can come back into your job. We don't have that for long-term care in many countries. And finally, what I'd like to say is we have a demographic issue here. And we have also been thinking a lot about a lot of the models of care we're developing, either care homes or one-to-one home care. And I think we're missing a huge opportunity for group care. I think we can reinvent it, and we can build in a lot more rehabilitation and proactive approaches to care that are much better than the models we've had so far. Thank you.
Okay, thank you very much. We'll continue now with Chui, is that correct? Yes. From Help Age International in Vietnam, saying something more about the role of civil society. We already touched upon it, but could you continue? You have some experiences and say something about that?
Yes. Thank you very much. And we all know that health is influenced by a number of factors. And care is not only the medical care, but also psychological support, and very important, the social care. And in the developing countries, especially in low middle income countries like Vietnam, where I work for, the health and care system is very much underdeveloped and already very overstressed. And in this context, the issues of the accessibility and adequacy and quality, that is something that really is the matter. And in Vietnam, for example, where I work, the country is a low middle income countries, and we are getting old before we are getting rich. So the country is one of the countries having a very fastest aging population in the world. It takes only less than 20 years for Vietnam to move from aging population to aged population. So it's very much short time to prepare, while we have very limited resources, both human resources and finance resources. So in this context, the role of the CBO, the community-based organization, is very, very important to fill in the gaps of the government and of the public health and care systems. And in Vietnam, Help Age International support the government to pilot and develop a successful community-based model we call intergenerational self-help clubs. It's a community-based model, and it targets majority older people, but also target the younger one, the near old, and they are from the neighborhood, and they join together to help each other, peer education, help each other with the income generation activities and lifelong learning. And they do the physical exercise daily. They join together to sing songs, to dance, and to help each other with the labor days, with the money, with the in-kind support, something like that. Then they also join together to do advocacy for the better age-friendly environment. They also send volunteers to help each other. So it's multifunctional CBO, community-based organization, get together to help each other. And this is very important in the context that in the developing countries like Vietnam, we have the huge issues of the migration. When the young generation migrate to the big cities for job, or not only in the city, but also abroad to other countries to provide care for the older people in the other countries, but leaving behind the older parents in the village, in the communities. And in terms of, and we are very happy to see that the government, after some times, they already put the model into the national policies. So now most of the provinces in the countries have the plan to replicate the models. And the need for the model is increasing because the government see that just with a little bit investment, but the benefit is very, very huge. And what do the intergenerational self-help clubs provide in terms of care? They do, as I mentioned earlier, they do the health promotion, physical exercise, sport teams, and they also do a lot of the health literacy. They invite the doctors to come to talk about NCDs and all those things, and they also provide the first level basic health screening, monthly monitoring blood pressure and also weight scale, and do the reference to the local healthcare station. They also do a lot of like mental health, like singing and dancing. That is what people want. If we want to talk about the people center, yeah, people love to sing and dance and talking together, gathering together. And then they do a lot of like lifelong learning and social social interaction, social participation. In terms of, so we talk that through these activities, the club do a lot about preventive long-term care. If we invest in that activities, then we can delay the momentum when the people need the long-term care later. And it's more cost-effective way. About the care, the club set up the volunteers. Each club about 10 volunteers. I'm sorry, that is still a volunteer-driven mechanism. However, in the low-middle income countries, it's very difficult for the government to have a higher level. So we still have to accept that kind of things, but they need to link with the health sector and other rehab services to do the other services as well. So each club recruits the neighbor, identify who in their neighborhood need care. What are the needs? They come and they do the assessment of the needs, and then they recruit the volunteers who are the neighbors, very nearby, so that they can easily provide the home care services for those who need. And because they know each other, they are from the same neighborhood, so they talk the same language, they know the culture, and then they know what their needs are. And then they also the volunteers provide a wide range of services, befriending. You know that I visited a 90-year-old woman who lived alone. She have a son, but the son migrated to the big city for a job. And the salary is also so low, and the son is very hardly to go back to visit her mom, his mom. So the 90-year-old lady with a bad vision, living alone, and the neighbor said, they always hear the television all night. And then they come and ask, why you put the television on all night? And the old lady said, I couldn't sleep. So, and I want some human voice in my house. So I just put the television all night to hear the voice of the person. So what she mean? What is the biggest need? She just wants someone to come and talk with her. That is her biggest need. So then the club sent the 3 volunteers. Someone go at the morning, someone at noontime, and in the evening, just to talk with her. That is already helped her a lot. It's not talk about clinical services or other services. What she wants is to talk, have someone around her. And then the volunteers come, and then they help her to cook with the food if she's not well. And they also help her to update the situation. What is going on in the neighborhood? Miss A is not well, but Miss A have the wedding soon in the next month, something like that. So she is happy. Oh, now she is updated with information around her. That is most important thing. And then she finds it difficult for her to walk, and the volunteer link with the clubs to do some fundraising and buy her with the walking stick and some cataract operation, something like that, and and link her with the government system so that she can access to the entitlements of the government. So that is the thing that the clubs do, and we found out that the most important thing that is a social support and to address the loneliness. That is the biggest need of the people at this stage. It's a declining functionality. And the beauty of the CBO is that they can be able to tap into the existing available resources within the community. Human resources. There are so many, 50% of the older people in Vietnam is the young, less than 70 years old. They are willing to do the volunteers. The human resources is there. Yeah? And the financial resources is there. We just need some mechanism in the community to mobilize all of these resources. And it's really the very good for the government to fill in the gap. And the CBO can also link with different sectors. If we talk about health sector, so they provide only health services. If only care, only some basic care. But here the club can link with different to provide comprehensive and integrated care for the people. And the CBO can do the older people monitoring. They advocate the local government service provider to be accountable for their responsibility. So in short, I think that the role of CBO is very important. And now the government sees the increasing role of the CBO, and now they start to invest. Just still very limited, but they start invest into the CBO. And in Vietnam, it's become the national government model now. Yeah. Thank you.
Thank you very much. I would like to ask you one question when you have to give a short answer, all of you, because you have touched upon some issues. And I mean, we have yesterday heard a lot about sense capability approach. With this set of functioning, which is important to live the life you would like to live. Let's assume we have two persons that have the same decline in functional ability. The one person is living alone. The son has migrated to a big city or migrated somewhere else. Is living alone. The other one is living close to the children or grandchildren. Would it be just to give them the same long-term care, or should we give them different long-term care depending on what kind of justice criteria you would approach to do that? I mean, that's just to indicate there's some kinds of justice criteria as well as needs assessment. So, in short, should they have the same, or should they have a different long-term care?
But just to try to clarify, I think what you mean is, will they have the same paid services or public services? Because family care is actually part of long-term care. So I don't know what your actual question is. If it's about...
My question is, should we try to emphasize and think about a system whether we get the same kind of care, or will we make a distinction between those where there will be a family provision or some other kind of support, and for those where there's no kind of support?
Yeah, I definitely think that there is a difference between the two situations. And so if you are receiving family care, that's often people themselves prefer to have some family care. But what you need to make sure is that when people provide that care, that you also support them. Because providing care to someone with a significant loss in capacity means that you really need to provide care in a way that can be a burden, and often appears to be a burden. If you look at people with dementia, and so caregivers of people with dementia show depressive symptoms at a higher frequency than just the general population. So you need to do some, and also anxiety symptoms and so on and so forth. So you need to do something to support them and to try to keep their mental health as good as possible. Because otherwise, if you don't do anything and just say, well, family can do the job, then also the family carers will break down and are no longer able to provide care after a while.
Other who would like to make a comment on this possible contradiction, as I see it at least, a justice approach?
Two points. First one is that one possible approach to that is to say is that the equity is about the experience of the individual we're talking about and their carers. So you could argue that what's proportionate in terms of the more external support, so to speak, for somebody who's also supported by family is it's proportionate if the end result seems to be roughly the same. Okay. The second point I want to make is that you shouldn't be asking me that question. The question is how do you answer those questions of justice, which actually slip through the fingers and can't be answered, completely with a financial perspective. And there are precedents for that. I mean, I'll give you a completely separate sort of answer situation. NICE, the National Institute of Clinical Care and Health Excellence in the UK, was often faced with questions about what is a reasonable cost incremental thing for different treatments. And are you willing to pay more as a national health service for people in the last 6 months of life with cancer compared with people of middle age with something else? Now, the question is, there's no medical answer to this question. So this is a question for citizens. So the way that NICE went about that often when it had these big questions was to pose these issues to a sort of representative group of informed members of the public and say, this is not a question that within our competence. What do you think is the right kind of balance between these things, unmeasurable justice questions? And so I would prefer that we would develop a way of answering the question rather than asking a doctor.
So it's a trick question, obviously, and but I know where you're coming from, and because you're also an economist. And then when we define equality and what's just, we have there's two main approaches that you find in systems. One will be equality of access, or equality of access to resources, equality to need maybe. And the other might be equality of outcomes, and to achieve, and I think there was a very good discussion on that yesterday. What we probably want is equality of outcomes. We want them all to have experienced the same improvements or achieve the similar improvements in quality of life. And it's quite clear, I think, that you have to give different things to these two different people. But I also want to stress the importance of making sure that we also take into account the outcomes of the children. And I'm just saying that again, emphasizing again the fact that when we look at the care relationship, it's not only the person who has lost intrinsic capacity, but it's also the welfare of the people who are providing the care.
Yes. Yeah, I also do agree. I think that what kind of care to provide, it should be based on the needs of that person, and also the capacity to provide the services of the locality, of the countries as well. But now you have the two cases. One is have no children, and one is have the children nearby. But sometimes if we ask the older people, it's not always that they want their children to care for them. It's not always. It depends on how the relationship is. Yeah. So we should ask them and also respect their choice.
Okay, thank you very much. I was just trying to raise an issue about some contradictory options in that one. Now I'll open, so if someone have a question or... Yeah, up there. There should be microphones in the room. Yeah.
I think the issue in long-term care, which I think Dr. N. Pure is a very important one in terms of the choices and the preferences. And I think what we need to emphasize is that choices and preference can only be made if they are supported with resources. Whether I'm able to, as you said, my preference is to live at home. I may not have anyone at home, but I need support. Or even if I have a family member, you need that social support. So the preferences are quite important in terms of understanding that those preferences can only be made if people have the capacity to make the choices, and those choices are not just mental choices, but also the physical capacity, the support systems that are required. So if I wish to live at home as a family member as a choice, I need to have the support that you talked about. And it comes back to the very fundamental question. We talk about financing, we talk about systems, But what is it that we are trying to do for the person that we are providing long-term care? It's the whole ethos of the humanity that we're trying to, the respect of the person, social justice we talked about. But that must be driven by the value of a human being. We have not talked about what is it we're trying to do in our health systems. It's the humanity in terms of recognizing each person, valuing each person, understand that person has autonomy and the right to autonomy. And that in itself is what we should be driving at, not whether the person can function or not. Even if the person can't function as we expect, as I think you mentioned that about, it's not important. Why should I go shopping? As long as I have someone with me, as long as I've got some contact, maybe better than contact, a relationship. Because as a human being, it's not just a contact, it's not just a volunteer coming 2 days a week or 3 days a week, it's the relationships. It's ourselves, humanity as a human animal, a human person. Right? What does that mean in terms of our social context, our social contract? What does it mean to be a part of human beings? What is our relationship to another person? What are our responsibilities to ourselves and to the society that we live in? And those are all issues that must drive in terms of what we're trying to achieve. So I think those are issues that I hope the panel can discuss.
Thank you. I will take a few one, and then if you can note and give feedback. I think there was one up there. Yeah, there behind there. No.
Sorry, okay. John Wong from Singapore. Can I ask the panel to address the feasibility, which I understand some countries are doing, about compulsory insurance for caregivers, so that when you reach that stage in life where you do need a caregiver, there's compulsory insurance that kicks in, and the insurance basically funds trained people rather than just the lower social economic class coming to care for, to care for people with significant needs.
Thank you. There's one of it. Before you give the microphone, just this literature. I mean, Niklas Barr from London School of Economics has written a lot of articles about that the case of long-term care is a good case for collective solution, and it's even more efficient than private solutions. Just an information. It was up there, then we take the last question before we have some answers. Yeah, up there.
Hi, Meredith Wise, Asian Development Bank. So one thing I sort of picked up from this discussion was the importance of social protection throughout the life course to really facilitate also care in old age. So social protection for caregivers coming in and out of the workforce, for spousal care for the individual. So just to articulate it, often social protection for carers is actually quite minimal. It's very welfareist rather than sort of productive social protection. So I'd hope in the future that's something that's looked at. But Adelina, you mentioned that financing is the elephant in the room. The other elephant of long-term care is the human resources. I think this question just coming up links the two quite well. And you also indicated that we need to really look at, in a system that has very low productivity, how to maximise productivity and utilise the human resources to its maximum, basically. I was wondering if you've seen any good examples or ideas looking forward, since this is a global challenge in human resources, and we all know the challenges, the low pay, the reputation, etc. Where is the progress really being made on this issue? Has anyone got any good examples, maybe from the panel or elsewhere on that? Thank you.
Thank you. Now we take a round of short answers because there are more people wanting to make questions. So who would like to start?
What I'm intrigued by is the notion of productivity in long-term care, and so I'm not quite sure what that means. Is it productivity? Is it as possibly borrowing from what David Canning said yesterday? About added capability, added quality, or is it a comparison between two providers who appear to be doing the same thing but at different cost? I'm not sure what productivity is. The second. Okay, fine. Okay.
So if I had the answer to the workforce issue, I think I'd probably I don't know where I'd be. Maybe you'd still be here, but this is the biggest, I think, the biggest challenge we have, and of course, financing is the other side of the coin in many ways, and that's why we worry so much about aging, because of the implications this has for workforce in general, not only in the care sector. I think we have to be very efficient, not only in terms of resources, but also in terms of how we deploy the human resources, the workforce. How to do it? There is no single answer. I don't think there's a number of avenues for looking at it. We definitely need to understand better, and I mentioned earlier this idea of group care. And this is a bit controversial to make this comparison, but very few people can afford nannies to look after their children. But that doesn't mean that they have to put their children in a nursing home or in a care home. There's all sorts of other ways in which we have found ways of addressing childcare. And the same applies to the rights of parents versus the rights of carers. I think we haven't made as much progress at addressing this other part of the human life course as we have with maternity. And actually, in the healthcare systems, we have focused a lot on maternity in countries and in childcare, child health, in countries where the birth rates are decreasing, and we have an infrastructure that we can potentially also look to move towards addressing other parts of the life course and addressing the implications of aging. So I think we will have to be very creative. There's no other option. We also need to learn from good examples of teams. I mean, the examples that you pose in Vietnam of people who maybe are not going to be, and as volunteers, they're not going to be a substitute for a trained workforce, but they can go also quite a long way towards meeting some of those needs. And I'm very excited in this project I mentioned in Stride. We are going to be looking at what we can build on. And in some countries, like in Brazil, we have the community health agents. They've been focusing on public health. Can they also be taking a role that is more on care? We know in practice they do. We know in practice that if a community health agent goes and visits somebody to measure their blood pressure, if they notice they haven't bathed, they're going to do it. And we know it's happening already. Can we build on this? Can we build on what we've already started developing and become more efficient and better?
Now maybe I can add something from the perspective of the Netherlands. What is happening now is that the whole ministry is trying to improve the image of the paid workforce, which is obviously very important to attract people also for these jobs. Now you see that is successful, so there are more paid care workers recruited, but what you also see is at the same time that they go away also. So they are attracted for the job, and then they are also lost after a while. So in that sense, it's also about how do you maintain these people for this work. And that is not so easy, because people often left, and we just had a huge discussion also at the inspectorate with care providers and carers to talk about this. They often go away while they're saying, well, we are not respected, or we are not valued in a way that we would like to be valued. But honestly, care providers are often struggling how to value care staff in the right way. How do you do that? That is difficult, and there's not an easy answer. So, I mean, there are lots of ways that they try, for instance, providing some vouchers for ice creams or whatever. I mean, they are very creative in coming up with all kinds of ways to show somehow that the care staff is valued, but how do you do that in a good way? So that is something. You can maybe also be more efficient, so that you need not that many care workers, And also, I think technology is seen as a possible solution, and to reduce the request for care staff. But honestly, I don't see that we solve the whole issue of a lack of care workers with technology. So, for instance, in October, I went with the ministry, the Dutch ministry, to Japan, because there is, as we all know, a huge number of older people. So the Dutch ministry wanted to know whether, what the solutions are that they see in Japan, to see whether that might be also an option for the Netherlands. Now, what you see is that in Japan, it's seen as the solution, technology. And also there is a little bit of focus on migrant workers, but if you ask, then only a few are allowed to stay, because you need to know the language, and often people cannot are not able to learn the language in a proper way. So actually what you see now, that's what a person that is experienced in the field in Japan told us, is that caregivers that are trained for Japan are not accepted, and now Germany is getting these caregivers to Germany for their workforce. So, well, I'm constantly thinking, what shall we do? Because you don't want to have a brain drain from other countries. On the other hand, if we don't do anything, I think in the end of the day, we will get an inflow of other countries for doing care work. So I constantly am thinking, maybe we should do some experiments, that we are also making a contract with the countries that send their people, so that both countries can benefit from it, and that it will be no brain drain or a one-way benefit. But maybe that is something for the discussion.
Sure.
We all talk about the issues of the lack of human resources as a carer, and actually, when we look at in Vietnam, when the government discuss about these issues, it's a big issues. And where are the carers? We export the carer, but now we lack of the carers in the countries. And then, if we look at the situation of Vietnam, we identify that per every person who need long-term care, then there are about 60 people who can provide care. Who they are, that is the young, near old and young old people who want to volunteer their time, who want to help their neighbors. But what they lack the training. They need the training to do it properly. They need to be linked with other services to do it in a more comprehensive and integrated way. So if you look at the aging as opportunities, it's there. We have labor resources, is there. We just activate them, organize them, recognize them, train them. So I think that is one of the solutions. About your first comment about value, autonomy, relationship, yes, that is very, very important. That is in the case in Vietnam when the older lady living alone, and the local government that we should bring her to the nursing home. But when the people come there, they say, no, I do not want to go. My ancestors live here, it's my house. I want to stay here, I want to die here. So the cultural issues is also something. And we need to ask them. We need to ask them for their choice. So it's very important in this sense. So I do agree with your comment about that.
Thank you very much. There'll be time. Yeah, was one. Yeah. So you first. And please be short in the answers.
Thank you, Jeff Halter, University of Michigan and NUS. I hope the commission and the panel think a little talk about many people working on various aging in place programs for people with disability. In the US, a very prominent and pretty successful model has been PACE, Program for All-Inclusive Care of Elderly, which identifies people who would qualify for nursing home, but allows the funding mechanism to be integrated for maintaining services living at home in place. And there are other programs like that, and I'd like to hear if you guys know of other models that are successful, and whether PACE, I don't know if PACE has been replicated in other countries in the world.
Well, thank you very much. This is a very exciting, at the same time, extremely complex discussion. And I just like, for the record, because I know you're writing up a report in the end, to join two types of literatures. So there's a literature, a very extended literature on social support. And I think it needs to be joined with the caretaking literature. So this research has shown us that we need to distinguish between emotional support and instrumental support. And if it has been found that if one person is supposed to give both of it, emotional and instrumental, that one of it will fall short, and it is mostly the emotional support. So if we rely exclusively on kinship relations or friendship relations, for that matter, to provide both instrumental and emotional support, we are running a big risk that the person who is taken care of and is receiving that support from this closely related person is losing out on the one person or the two persons that are emotionally and used to be emotionally close. Because the stressors of instrumental support on a day-to-day basis are so big that they will overtake the emotional rewards. And so, in my mind, the challenge really is, how can we make sure that this emotional support is maintained in a phase of life where the person that needs to be taken care of is undergoing developmental changes? We don't think about it that way, but it is developmental changes. And in the front of us, we see an adult person changing due to the physical constraints, due to the mental constraints. It's actually becoming partially a new person. And we need to support that development and not only look at how do we deal with the symptoms. A family member, be it a spouse or be it a child, has an enormous challenge to realize the fact that this person they used to know is disappearing in front of their eyes. And at the same time, then we require this very same person to provide instrumental support and day-to-day support in the closest intimate parts of one's life. I think, frankly, it's overcharging that relationship. And so I think there is no choice but to implement a sustainable system as part of the healthcare system that provides the instrumental support. And I think we've heard very good model examples that are underway that place this care in a community setting, which is, I think, a very nice sample and way to go. I'd just like to alert us to the fact that there is a lot of development going on in the sense of increasing disability, and we need to make sure that we are recognizing the new person that is emerging out of that disability. That's particularly prevalent for dementia. And we need to give the dementia patient a chance to realize this new person with limited capacity, which the family members will not let them become because it's too intimidating. Sorry.
There was one up there. We take all four. Yeah.
Andrea Meyer, University of Melbourne. I would like to ask the panel to elaborate a little bit on the interaction between care and cure. I think that we really have a model of cure, which is fantastic. But we see attempt to cure and apply that to individuals who are in care already with significant capacity loss, which might not be the best model, which is very organ specific. And we try really to cure lots in a caring individual we have to care for. So please elaborate a little bit on the ideas how to get another model in medicine to actually adapt that to the ones who are already have lots of capacity loss, because we have lots of multimorbidity, lots of polypharmacy, and nothing of our models we are applying at this moment in time is actually evidence-based.
We want to take one more with short question, because there are more short answers, very short. And then
John Beard, it's just a fantastic panel and great input too. I'm wondering if we have a problem in how we frame the issue economically. And we tend to think, okay, we have an older person who's frail, needs support, that's a cost I have to somehow meet, and it's a burden on society. Whereas I know in some places they've been thinking about this in a very different way, that expenditure could actually be a catalyst for the creation of care economies. And by creating a care economy, you're creating jobs, you're expanding, you're contributing to socio-economic growth. I just think it's a very different way, and if we think in that different way, it may help us think about how we make the investments which would catalyse the systems, which I think you've really covered beautifully.
Okay, short answers, because there's more questions out there. So, Turi, start.
About the first, about the funding channel to the community, so to enable the home care. I think this is very important. In Vietnam, there is a government policy that those who are eligible to nursing home but prefer to stay at their home, and there is someone to agree to be the carer, then they will receive the government money for that. However, the challenge is that the allowance is very small, and it's not enough. And these carers are not trained, or are not like, how to say, the link with the service, other service providers. So it's a challenge, but it's a good start. So I'd like to share that. Yeah.
So we missed out the insurance question earlier. Well, you answered it a bit, but what I wanted to say is that there are other mechanisms. So some countries are doing really well funding care out of taxation. And these are countries where normally there's already quite a high appetite for paying taxes, or that maybe there's a high level of trust in that the government will spend the money fairly. In other countries, maybe there's been more resistance to that, or maybe they have already a tradition of having a social insurance system with contributions from the employers, and that's already well established. And in that case, it makes a lot of sense to build on that. And insurance, we know that private insurance doesn't work very well. I'm sorry about the US, but each time we talk about you in terms of long-term care financing, you come out as the example of what doesn't really work, because it becomes when people have to pay for the whole risk of care, what we find is that there's lots of, and only those who can afford to buy insurance, the products become extremely expensive, and those who are less well off cannot afford them. Therefore, you're only going to cover a very small part of the population. Social insurance system doesn't have to be completely public, and Singapore is an example. It's not quite a social insurance system, but it's an example of a great innovation in this. In Germany, in fact, the social insurance funds are non-profit organizations, so that there are all sorts of models and appetites for different type of political systems. So quickly zooming, in terms of interventions that work, and we have some really, really good examples of care approaches that work. PACE is a fantastic example. We're now doing a review of low and middle income country experiences in interventions for people with dementia, because a lot of the models that we have are based on an infrastructure that maybe is not available in other parts of the world. So we're hoping to also learn, as part of the STRIDE project, on what is working in low and middle income countries and what has been studied. And I think that there's a huge opportunity also for high income countries to learn from some of the approaches that you described that are just so rich and so wonderful at mobilizing much more support and much more, I'd say, social interaction than the models that we have had in most high-income countries. Let's go quickly. In terms of the interaction between care and cure, we've done some modeling, some projections of the current health, the current characteristics of the people who will be aging in England in the next 30 years. And what we have found is that increasingly we'll have a population with much more complex needs who will be using care. So we had, until now, quite a lot of people who only had dementia in a care home, or who only had some sort of functional disability and maybe one chronic condition. But if we continue in England with the current health behaviors and the current approaches to dealing with conditions such as diabetes and the current rates of obesity and hypertension, we're expecting to find that the majority of people living in care homes in particular are going to be people who have at least 3 chronic conditions, dementia and functional disability. And the type of care that those people will need and the kind of professionals that will need in these care homes to adequately meet their needs is going to be very different than what we've had until now.
Just for one, I'll address that question in just the one that Professor Meyer posed. The situation that Adelina describes is already my experience. I mean, in a care home, individuals with many conditions and quite significant disability. So the issue arises constantly today, not in the future. I think that the principles that we look at in terms of, for example, the WHO model, where towards the end of life, the balance of utility of treatments which have their primary purpose as cure becomes progressively less, but there are still medical treatments that are actually helpful in terms of comfort, relieving symptoms, and also sometimes preventing further loss of capacity, which would be detrimental in terms of experience of the individual. So these are quite complex decisions, and I completely agree with Adelina. I think there is a complexity there. I don't think the principles of the judgments that you're making is in principle different. That is, that the clinician's job is to understand the likely trajectories, the impact of medications on those trajectories, the burden associated with an intervention, and the patient's job is to make evaluations of those different options. So I think that theoretically the model is exactly the same as any other phase of an individual's life, but it's more complicated, and therefore it's often done badly because it's done by people who don't have sufficient understanding of those things I mentioned to have that conversation. So the practical implication of that is that whatever the model of provision, there has to be close integration in practical from the point of view of the individual person with some competent medical practitioners. Now, exactly how that's organised can vary, but there has to be that interaction. So, there's not a transition. You used to be a patient, now you're a resident of a care home. That sort of that thinking is not helpful.
Okay, I saw 2 more before, and that would be the last question. One here.
Thank you. I'm Margriet Kelly. I'm a consultant to the commissioner process from the US. It occurs to me in listening to this panel that when we think about most of the systems for care for people with significant capacity loss, the reliance on family and unpaid and paid carers is really exacerbating broader societal inequities, gender, wealth, race. And so is actually actively doing harm to the healthy longevity of a whole second set of people who are not the person with significant capacity loss. And a lot of the solutions, and ideas that you've described seem very promising in terms of kind of mitigating that harm. But just as a thought experiment, if you got to start over from scratch, can you imagine a system that actually does the opposite? That reduces inequity for the other person in the dyad or the group or whatever it is, while also doing a better job of caring for the person with significant capacity loss, which is maybe kind of like John Beard's question, but more with an equity frame rather than economic frame. But I'm really curious, just based on your experience and your knowledge base, what does your imagination tell you could be possible?
You want? Okay. Then you'll answer that one, and while you're answering that question, just give me, all of you, one example of what you find is evidence-based intervention which will help solve the issue of long-term care. Just one intervention.
Okay. Shall I start? So I forgot earlier also to answer one more question, but there's a relationship between those two. And I talked about the impact, the economic impact of providing care for people of working age. But there's some very clear evidence that shows that when we talk about the impact on carers, it's a matter of the amount of care they are providing. So there's a lot of carers in the world. We have about 2 million, or more than, I can't remember, but in England we talk about millions. But the amount of people who are providing more than 20 hours per week, these are the people whose health is seriously compromised. And I recently came across a very interesting piece of research that was comparing the Netherlands and the UK. And the Netherlands is much more generous than the UK. And what happens in the Netherlands, well, they looked at people and how much care they were providing and what were their mental health outcomes. And what they found is that the mental health outcomes were identical in the Netherlands and in the UK. And for people who were providing high-intensity care, their mental health was really seriously compromised. The difference was that the amount of people who were providing high-intensity care was much higher in the UK than in the Netherlands, and that's because in the Netherlands there's high availability of replacement care, which means that there's a partnership, there's still a lot of carers. You have as many carers pretty much by head of population. Is the amount that they provide and the support that they have and the ability to combine the care with other activities of their life and perhaps to get away and protect their emotional health, as you mentioned earlier. And in terms of inequality, inequity, I think we have, long-term care is just making even bigger the existing inequalities and inequities that we have in our systems, and I've particularly been focusing on the difference between men and women. In the UK, men earn 36% of income. We have huge gender disparity both in workforce participation but also in the pay you get once you're employed. That means that women are more likely to think that they can give up their jobs, and then because they don't earn that much anyway, so it's better that the husband stays at work and the woman doesn't go provide the care. But then later on, say they divorce, when it comes to the pension of these women in the future, it will be seriously compromised because of that. So what the lack of social protection for these carers, or the lack of replacement care, that means that they don't have to give up their job, it means is that these inequalities are exacerbated. And finally, just to say, the one thing that I would definitely think is quite cheap to implement, and I would like to see every country do, is care leave, protected care leave for carers, that they can go back into their jobs without facing any barriers. Okay.
You've asked us to give one example and to respond a bit. I just want to say one thing about the issue of efficiency and the thing about the market. I'll just give you some very brief figures. In England, local authorities, the variation per 1,000 person over the age of 65 10 years ago, this has been out of date, in terms of the numbers of people in care homes was 2.4 to 12.2 per 1,000 people over 65, a variance not explicable by differences in the nature of the people. If you look at local authority expenditure, the proportion on care home, spending on care home was 71% to 25%, and the proportion for care at home, at the person's home, was 29% to 74%. Now, what that tells me is one, that the judgment and decision making is highly variable, but secondly, that actually the supply side is making a big impact on the way in which we respond to the long-term care needs of people. And there's at the moment no supply side interest whatsoever in resolving that discrepancy and difference. So that in terms of integration, it has to be based on data, much more thought about actually how you bring together those different players to actually have something that would be more likely to be care at home and probably almost certainly more sustainable. Now, the second thing, one intervention you talked about, I think an important intervention is future healthcare planning. Future healthcare planning, which gives people an opportunity to express their preferences about potentially predictable trajectories, which includes sudden crises and death and end-of-life care. Specifically, if you introduce practices in a care home setting that has those conversations in a structured way with individuals and others that they want involved, family if they want involved, people are more likely to die in the care home if that's their choice. They're less likely to be admitted to hospital for a futile stay, and the resources spent by the healthcare system is less. So everybody's happy. So that's a good intervention. But it requires some expertise to do it properly. You can't leave it to the average care home provider.
Okay, one intervention. I think I would, yeah. I need to choose. Well, yeah, there are many, but well, I would start with the support for caregivers, the training and support for caregivers, and maybe that's also. I mean, we have all our backgrounds. So I'm a psychologist, and having done a lot of research in this field, I really see the importance of people being supported, because we are often thinking that it's an easy job that you can do without any training, that and that is something we really need to change. And I think even in countries that with low-income countries, this might be possible to do without too much investment. Financial investment, I mean. And also, for instance, at WHO, we developed iSupport, which is an training support tool for caregivers of people with dementia that can be easily translated and adapted in different languages for different cultures. This is, for instance, one of the options that are available and easy to use. On the other hand, and that is in line with what you are saying about inequality, when I look at all the research that has been done on supporting caregivers, in a way we are reinforcing the status quo that women provide the care. And that is something, which I don't like, because I really think that we need to look to other people from the surroundings of people with dementia or with other declines in capacity, including men, but also older people themselves, peers, volunteers, people in the neighborhood. And it's like in the Netherlands, I was far away from my parents, but there are also people who need care in my own environment, so maybe you can have an exchange in that respect. So, I think these things are important for me.
I do support the solution. That is training for the caregivers. So in the CBO, caregiver now, they should be trained properly so that they can do better their jobs. The rich people can access to the high quality private sector care. The poor people, very poor people, is already protected by the government policy. How about the middle class? We need someone. We need someone to care. So that is the very huge market, the middle class. The need is there, and the human resource is there. So we need the training, organize them, so that we can fill in the gaps.
I think I will raise up. Thank you for all your comments, and I will not try to sum up. I can see Sharon has already written a whole list over there. So I will say a few words, so you can compare whether we have reached the same conclusions. And that's always a good way of doing it. But as I see it, there's something still about an issue about quality in long-term care. There's an issue about how is it lived life by different people, how to have something about self-esteem, self-actualization, and we have a complex measurement of these issues. And we also have something about, so to speak, what about the carers? There's been an ongoing discussion here. And I might and dare say, because I have the last word, it's always nice for this session, you talk about a risk of lack of workforce. But it might be that welfare technology will be one of the solutions to that question as well. But that's open for your next session. But I mean, sometimes new welfare technology, and I'm sorry I come from a country where we talk a lot about technology changes, even the risk of that labor force will be redundant by artificial intelligence, but it might be a way of doing it. But with all the things, we have different approaches in different countries, and community care and different kind of interchange of community care might be a solution. Although, as we also touched upon yesterday, voluntary work might work some places, but we cannot be sure about voluntary will be there. I mean, I always teach my students, we have government failure, we have market failure, but we also have voluntary failure as issue one should be aware of in the classical way of it. We need financial sustainable system, and money spent in one area can't be spent in another area. That's also the classical dilemma in economics one needs to be aware of. And we need to think about also re-enablement, not only talking about cure, but also re-enablement. And as said, somehow, it's good to think about that the elderly would like to stay at their own home and in their own life. And we should balance these perspectives with the way the healthcare system and the long-term care system works. And by this, I will say that we now have a break. And would you please say thanks to the panel for all their comments and for all your questions.
Thank you.